Hi, everybody. I'm Wendy Murdoch, and this is Webinars with Wendy. We will be doing spotty webinars for the next couple months because I'm doing some traveling. So we have Ann Marie today. Yay. I'm so excited about that. And we're kind of just putting guests in where I have time in my schedule. And of course, we will send out that weekly email. So if you make sure that you go and sign up for the emails at murdochmethod.com. Where do you sign up? We'll be sure to get you those emails so that you know what webinars are coming up. And of course, you can see all of the webinars on the Surefoot Equine YouTube channel, so you can watch them whenever you like. Today, my guest is Ann Marie Hancock, and she's back. I think this is number 4. Yep. And this is a really hot topic. I'm so excited to learn more. So I'm not going to spend a lot of time on the intro. We're going to roll right in and let her get going. And I know that you're going to really enjoy this. She's got a great lineup of information for us. So welcome, Ann Marie. Thank you. Thank you for coming back.
Well, thank you. Okay, I'm just going to share my screen and get started.
I'm going to make you co-host.
I think you did.
Nope, I didn't. Now I did.
Now you did, so I can share my screen.
Yep.
All right, sweet. All right, so you guys are seeing this. I haven't pressed the slideshow button yet.
Yep.
But all right, so we're going to talk about head shaking and what causes it and how do we treat it. And what I thought I would do is very briefly kind of tell you guys, we're going to start with looking at all of the conventional explanations for it, and what do we as veterinarians say, and then I'm going to kind of segue into a slightly unconventional, and then we're going to go into the more holistic approach and kind of give you that too, so you guys can see where you're at and kind of make some choices as far as what might fit for you. So that's where we're headed. So starting kind of with the conventional, so we keep renaming things, like, as you know, if you've been in the veterinary world for any length of time, every 5 years we have to rename all of our diseases, because that way we can get new research grants and things are more exciting that way. So right now we're calling head shaking trigeminal mediated head shaking. So there's at least an agreement, which has kind of been there for the last 100 years, that has something to do with hypersensitivity of the trigeminal nerve. And the trigeminal nerve is what innervates the sensation to the entire head. So it's going to do inside the eyeball, the upper eyelid, the lower eyelid, inside the sinuses, where the teeth are, the roots of the teeth, the temporomandibular joint, all of those things. So, it's a lot of sensation there. Based on the studies that have been done in the last 20 years, it looks like it affects 1 to 2% of the equine population. Most of those studies are from the UK, and some of it is head shaking. So that's related to the season of the year or the light. So, this picture is, of a horse in the sunshine. So I definitely see that. I've had people tell me, I can ride inside, and when I get to the doorway, then they start to do it. I get past the doorway and they're fine again, or they're fine in the indoor, but if I try to ride outside in the summer, it's terrible. So that's part of it. Some of them only do it during exercise, and some of them do it all the time. So I think that if you have one that you can come up with some sort of pattern to it, it's going to be a lot easier to treat. So knowing whether or not it's related to, are you riding, or are you tacked up, or does it have to be outside? These are things, is it a certain season of year, that can make it a lot easier to come up with a treatment plan. And like I said, it's probably hypersensitivity of the trigeminal nerve. So first thing you have to do before you head down the rabbit hole of the unusual that we don't know the cause of, where we're trying to come up with some way to treat the trigeminal nerve, is you have to rule out all of these things that could be causing it. So likely things are ear mites, ticks in their ears, anything that could cause, pain or sensitivity in the ears, those oral plaques, those big white spots they get on their ears, an inner ear infection, cranial nerve dysfunction. So you want to look for facial paralysis, or problems with a droopy eye or a droopy lip, or too much, fluid coming out of any duct or gland, right? So excessive tearing from the eye, excessive salivation, all of those things are hints to cranial nerve dysfunction. Pull or neck pain or injury, I think that one's probably a big one, and probably kind of gets ruled out a lot when it probably should be, a continued part of the, the question, because we don't always identify it well. And so if you have a horse that has maybe one side of its jaw that has more musculature than the other, that's a hint that you have asymmetry and you might have pain in a TMJ or pole area. If you have a horse that twists his head and rotates it when you ask him to bend one way versus the other, that's a hint that there's an asymmetry or a lack of motion in one side of the pole. So you might not consider that to be painful, but that's something to consider when you're looking at these head shakers. Like we said, eye pathology, so a tearing eye, an eye that's more swollen than normal, guttural pouch disease, because the temporomandibular joint kind of lies within the guttural pouch. So they have a problem there. Tooth root problems, because that's right where the trigeminal nerve is. So any sensitivity to the sinuses or any teeth problems, any dental abnormalities. This picture up top shows a really nice mouth right now, but this horse has an abscessed tooth, right? But sometimes you'll see before the abscessed tooth, this tooth on the bottom might be high. And so the reason the tooth on the top gets abscessed is pressure from the bottom tooth, creating some motion and some sensitivity to the root and the nerves on the upper tooth. So you could have something that isn't at the point where you have a tooth root abscess, but it might already be creating pressure. So taking a look at dentistry, making sure that they're nice and balanced can be important. And then EPM is in here. I think that's because anytime we don't know what anything is, we call it EPM or Lyme, right? So those are like, you just have to throw those in there. So I think that we could do hours of discussion on whether or not Lyme or EPM is a symptom or a pathology, right? Because I think both of those are often labeled as the problem when they're just one of the problems that the horse has at the time. And the real problem is maybe the immune system or the gut or something else. So, but it gets put in there when you look at your categories. Conventional treatment. So any of you guys who have had head shakers probably have used a nose net. These are really popular, especially with the light sensitive horses. So you can use these when you're riding. It's supposed to maybe kind of stimulate the trigeminal nerve just enough to create desensitization. So what you're trying to do is you're trying to, it's kind of like what you do when you go into a room and something smells bad, and then after you've been in the room for a while, you can't really smell it anymore because your body desensitizes to the smell. So you're doing the same thing with sensation here. You're putting on a nose net and you're sensitizing the nerves of the trigeminal nerve, the maxillary portion, to the, the feeling of that nose net. And then hopefully the nerve will kind of desensitize and stop signaling long enough that you can ride. So that's what that's doing. And those seem to be pretty effective about 50% of the time. So a lot of people have success with them. One of the other things that people are doing is looking at diet and nutrition. There's some question that maybe calcium could be out of, maybe not balanced. And so that could be creating some problems with either calcium or potassium, which are important for what we call action potential. So the way the nerve stimulates is it kind of has to release sodium and potassium and calcium in a certain level to create an electrical stimulation through the nerve. So if that isn't right, then maybe that could be part of the problem, or it's oversensitive. There's another comment about that overweight horses might be more likely to get head shaking. I think what they're actually probably seeing that they haven't labeled is that a lot of horses that are sort of on that metabolic spectrum, or the hyperinsulinemic horses, tend to be really inflammatory. That's part of having high insulin. So I think that the overweight part is really more that they're inflamed to begin with, and that's just a part of that. So then, we start talking about other treatments, more conventional, veterinary treatments. A lot of people use antihistamines. So these are the two most popular ones that were in the papers that I saw, which is cyproheptadine, which can also kind of sedate the whole system, and hydroxyzine. I also see people try Zyrtec. That's another one that's over the counter and easy to get. So sometimes people will try Zyrtec. So what you're doing with all of those is you're trying to decrease inflammation and decrease signaling. So you're just trying to numb the response. There's a couple people that have come up with some studies now, I think out of UC Davis with Dr. Madigan, who does the majority of the head shaking research in the US. And they've been looking at magnesium and boron, and that says melatonin, but it should say melatonin. Sorry for the spelling error, I'll fix it. So those three things can also really help against sedating the neurotransmitters, trying to relax that hyperstimulation. So he actually mentions MagRestore. That's the one he puts on his site as what he recommends. And that's actually the one I like the most for magnesium supplementation. So I went ahead and listed it. It's from a company in California, and it's really highly absorbable. And the other thing is they give it at a really high dose. So they're giving 20 grams a day. You cannot overdose on magnesium, except at some point it causes diarrhea. So it's a very safe thing to supplement. And you basically supplement to the point where you have loose manure and then you back off. And so I think that's why it's a popular one, is it's pretty safe. There's a supplement that Platinum Performance is making now that's magnesium plus boron. The magnesium level is like 12 milligrams, so not as much as the MagRestore, and a little bit of boron. And they have a study saying that it's working really well, so that would be another option. I haven't tried the melatonin yet, so I'm kind of interested to see, but that is something you have to start, and you have to do it every day at the same time. So they recommend giving 15 milligrams a day at 5 p.m. And you just do it. The ones that seem to have the most success with it do it all year. But when you do that, you may not get proper winter coat shedding because you're not allowing the horses to understand day length. You're kind of affecting their ability to understand the day length when it changes. So that's why I put that note down, so you guys know that. And then we get to like real, more heavy duty drugs. So the ones at the bottom here, some of these are controlled drugs, so they're ones you definitely have to get a prescription from your vet to get. The I hate this word, it's so hard to pronounce. Carbomazepine is used for seizures and for trigeminal neuralgia in people. So that's why it's on that list. Most of the veterinarians are thinking that trigeminal neuralgia in people is not the same as the trigeminal head shaking in horses. So that one may or may not work. We're kind of moving away from thinking that they're similar diseases. The next one is a sedative fluffenozine. So we used to use that a lot for stall rested horses to kind of calm them down. So you're just calming down the nerve systems. Phenobarbital, again, that's a sedative. We use it as an anti-seizure medicine too. So calming the neurotransmitters down, calming down the nerves. And then gabapentin. So that would be more like nerve modulating, as in trying to decrease the pain response and the sensitivity. So a lot of people use gabapentin for sciatic pain in themselves, or something like that. So it's more to calm down the nerves if it's a nerve pain. So I'll use gabapentin sometimes if I have a laminitis case that isn't inflamed but is still painful. Sometimes we think maybe they have pinched nerves in their feet, and it can be helpful there if that kind of gives you an idea of how you would use it. So that's kind of our conventional approach. That's what there is. If you Google head shaking and Dr. Madigan and UC Davis, or I think he has a website that's called headshakinginfo.org. All of this sort of stuff is on there. He's got some great explanations. And I mean, he's the go-to guy. If anybody has done any research, he's the one that does it in the conventional world. So then I was going to kind of present to you guys just a couple other viewpoints. So this is another veterinarian that I think she's out in the Midwest. And she has an interesting perspective on a lot of things because she comes from a background where she was a electrical lineman before she was a vet. So she looks at things through schematics, and she is really into understanding anatomy and kind of breaks things down that way. So she has some really interesting points of view on shivers. I've listened to her stuff on that before. It's kind of interesting. And she does some interesting stuff with the thoracic sling, just kind of a slightly different way of looking at things. So what she thinks is that it's often a training issue or injury or trauma. So in the majority of cases with head shaking, it occurs or starts sometime between the horse's age of 6 or 12. So they've been in training, maybe things are getting harder, maybe there have been some repetitive strain on parts of their body. They've probably had the opportunity to pull back from the cross ties, have a trailer accident, do something they shouldn't have under saddle. These sorts of things have happened in that age period. They're competing more heavily. So she feels like it's often related to some of that. And she likes to really see, like, when do they do it? So go ahead.
We have a comment from Dorothy, and I think this fits right in here. I'll just go ahead and read it. I associate my horse's tendency to head shake to his castration that went very badly wrong and left him with serious scarring in the right groin area. He head shakes anytime he does something that stretches his right hind out behind and is clearly hypersensitive around his left ear. He can't tolerate a brow band around his left ear. I am thinking of fascial connections across the diagonal leading to the trigeminal nerve being irritated by stressed fascia, ? He's improved enormously as he's become straighter and a lot of the body work targeted at his fascia. I'm wondering how much of his head shaking is in general is associated with the fascial net distortion and inappropriate tightness.
That's awesome. I love that question. So I think that fits in right with this. Like, if you're going to talk about fascial pools, right groin area usually feeds into left SI, and it also feeds into right lumbar area, which will then cross and cause a restriction on the left shoulder, the left cervicals, and the left TMJ. So if you truly had like scarring in the right side, from a castration, then that would be the pattern that you would see. It would go across exactly like what you're saying. So the treatment needs to be releasing the fascia in the groin area. And you could probably even get a veterinarian to go internally and break down the inside of it, because the psoas muscle and the inguinal ring are right on the internal part. So you can contact them better with a rectal exam than from the outside. Lots of psoas stretching and releasing. You might even have like a little problem on the pelvis, but you could actually have something on the left pelvis that's a shift, from the anesthesia, because that would be more intimately associated with that left pole. And then your real problem is up at the pole on the left. So I think, yes, there's a pull from the hind end, but there's probably a lot going on in the left TMJ, left pole region that's causing more of the head shaking. I think that would be a very plausible thing to do. I would definitely look at teeth in that case, because if you have slanted incisors, like we're finding, slanted incisors means an imbalance in the mouth, which means a lameness or asymmetry behind. So you have an asymmetry behind in this particular case, right? We know we have some sort of fascial pull on the right hind. So I'm guessing that if nobody's balanced his teeth, then he's going to have slanted incisors, and that's going to feed into perpetuating the head shaking. So I would definitely look at that. And then I would kind of treat that whole area. So we're going to kind of talk about how to treat it as we go through this, but she's right on target in that oftentimes that works out exactly that way. And then I look at fascia. I'll often see that a psoas restriction on the hind end will create a hyoid restriction on the front end, right? And that hyoid is right where we're talking about, the hyoid kind of feeds into the stylohyoid bone, attaches into the TMJ, which is right where, the trigeminal nerve and all these other nerves are going to exit. It's right near there. So it definitely, you can definitely see it from a fascial restriction, and that would be a great example of how you would get that. And I think what Dr. Clue is saying too, that kind of fits into that with the positional stuff, is that often that fascial restriction can be something that's come over time with repetitive strain, like a horse that's been in hyperflexion in work. Those fascial areas under the jaw will be really tight. And then those can be part of the problem, because then they're making this whole area tight, which is where the trigeminal nerve is. So being really aware of that as part of how you look at it is critical. So yeah, I think you're definitely on the right track with that. So, that's kind of what her idea is that we have to look at it as, I don't think there are wild horses, or there aren't a lot of wild horses that have this. So it's probably something that they get because of things that happen to them because they're domesticated, whether that's injury or trauma or wear and tear because of the way that we're riding, or whatever it is. I think that's something to consider. And then how do we change that? So if you had a horse that you noticed did a whole lot of it when he was on cross ties, then maybe you need to change that position. Like, don't put him in cross ties. Where is his head when he's in cross ties? Where's the halter? Is there pressure somewhere it shouldn't be? Or if he's doing it when you're riding, maybe you need to play with, rein length or head position. Move the head up, move the head down, move the nose out, move the nose to the right, move the nose to the left, see like what kind of things create the problem, and it might help you figure out where that fascial restriction is. Yeah. Does that sound like a good answer at this point?
Yeah. And she says she does dental care with him, has his incisors done when he has his dentist.
Awesome. That's great. Yeah. So we'll go through we're going to go through Dr. Clue's take on how to do this, and then we'll go through kind of my take on how to treat these. And it might give you some avenues of things that you could look at for sure. So, we just have to figure out how do we get to the bottom of it. So what she does is she makes sure that after she does her treatment, that people don't go back to the behaviors that were causing the problem. For example, cribbing collars or grazing muzzles, anything that's causing that position that you don't want. I did have a case that I was unable to work the horse up completely because the owner wasn't sure if she wanted me to do like a full osteopathic exam. So we had to kind of do pieces and parts. And I could get the horse to stop head shaking until she put the grazing muzzle back on. And then she'd go right back to head shaking. And so, if you can't change the inciting event that's causing it, you can't fix it, right? So you have to make sure that people are willing to remove whatever is going to be the trigger for it as well, which I think is a really good point. So what she does, which is very conventional, she's kind of looking at unconventionally and then treating conventionally, is she injects the branches of the trigeminal nerve, and then she applies shockwave to the pole. So I think that's a very traditional approach to treatment, but an unconventional way of looking at the problem, which is kind of cool. It's like a nice little mix. Personally, I'm not a shockwave person, because I do body work, and to me, it does a lot of inflammatory damage to the tissues. I don't like it, but that's just because I'm doing my own version of tissue work, right? So,
and shockwave, briefly, what is shockwave?
So shockwave it's a tool that a lot of veterinarians have, at least in the performance world, and it delivers high velocity, high acceleration impulses multiple times to an area. And what they found is that when you do that, you get it's a nice amount of time of analgesia afterwards. So it numbs the area. So you're literally numbing the area. And I think that when you have a nerve pain, that's one way to treat it, is to numb it. When we start talking about polyvagal theory, I think that a lot of what veterinarians do is numbing the sympathetic nervous system. So I'll kind of explain that in a minute. And it's effective, but I don't think it's as effective as we could be, right? It's better than not numbing it, but we could eliminate the pain so we don't have to numb it. Like, that would be one step better than just numbing the pain. Right. But I do think that she's on to a really great idea in that she's finding the source of the problem and doing something about that versus trying to do something systemic or whatnot that may or may not work. So I do think it's a really cool way to look at it. I sent some links that I sent them to you, Wendy, that have like there's a podcast that she did that explains a lot about head shaking. So we'll put those links up for you guys.
Yeah, send it to me and I can put them in the description.
Yeah, so then you guys can listen to her stuff if you want. But it's kind of cool. It's a nice little summary of a bunch of this stuff. So here's another one that's really interesting that's been out for a while. I think it's a British Equine Veterinary Journal article, and it's a company called Equine, and they have you put in needles or they're little stimulators, and you put them in right at the infraorbital foramen. So this is right where the trigeminal nerve comes out to innervate the face. So you put one on each side, and then you connect this stim unit to another one that's at the base of the neck on this side, and you do the same thing on the other side. And you run them you have to sedate the horse to do this, because you want them to be actively twitching. So it's E-stim. It's not like electroacupuncture where you just, turn it almost to the point of twitching and turn it down. You want active twitching for the whole time. And you'll get a twitch of the muscle between the nerve at the base of the neck and the muscle there and the needle that's in the head. So you'll get twitching at both spots. And you turn it on like they have a whole protocol. It's a lower frequency for 10 minutes and then a higher frequency for 10 minutes. And so it's supposed to create kind of a reset for the nerve. And it's supposed to kind of have a short and long-term analgesic effect. And so what they found with these guys is they get about 10 weeks of remission the first time. And then they go back, and then maybe they get, 16 weeks the second time, and they can keep, if you continue this, you'll get longer and longer periods in between needing treatments. So it's about a 30-minute treatment. I've done it just using electroacupuncture needles, and it does seem to really help. So it's another option if you have a horse that you're trying to work with. It's just one more thing you can try. There are some studies out there that have shown that acupuncture and chiropractic doesn't help, but I haven't found that study. I just know that there's people who have said there's this study that shows that it doesn't help. So maybe we need to do another study. I don't know. So, but that's where we are with that. So this is one more thing that we could talk about. Okay, so I wanted to get to this point because I want to kind of spend a little time talking about my approach, but I wanted to make sure you guys understood all of the other approaches first. So before
can I ask you one question, and we have one question on the
okay.
chat. So do you find that there's any kind of association between vaccinations and head shaking?
Yes, I just had one this last month that we worked on that had head shaking last year, and we treated him osteopathically and he was fine. And then we came out this spring and he was doing great, and they wanted to do all the shots. So we did all the shots, and a week later he had violent head shaking, like just standing in place with his nose twitching. And so we came back out, I treated him osteopathically, and I did this Equipens, my electroacupuncture version of it on him, and he hasn't head shaken since. But we definitely discussed that. That was what we decided, is that from here on out, he's getting titers and he's not getting vaccinated because he's 25 and he has plenty of immunity and he doesn't need the shots. So yeah, I definitely see that. I think anything that creates inflammation that can set up that response can cause, trigeminal hyperesthesia, right? So anything that creates a response that's inflammatory or immobilizing an area that the trigeminal nerve goes to will cause hypersensitivity, right? So you have to look at those as like the causes.
So basically, then you recommend that if someone has a horse that head shakes, that they should do titers before they do vaccinations, so that they're not creating too much inflammation and causing more problems.
Absolutely. Yeah, I think that would be a great idea. If you have a head shaker, you should really be considering limiting anything inflammatory that you're doing to your horse. Okay. Yeah, and vaccines are one of them.
Kathy says, my head shaker has a pink nose and it was getting sunburned. We have eliminated endotoxins from his diet. He also wears a fly mask and sneezes 5 times each time we put it on. We have balanced his minerals. I'd like to try boron. His head shaking only happens spring and fall or on sunny days.
That definitely sounds photic. Like, I wonder if maybe his might be, yes, he's pink skinned, so that could be part of it, but he could also have maybe something going on in the ophthalmic branch of the trigeminal, which is harder to get to, right? Because it doesn't have an exterior opening. So there are 3 branches to the trigeminal, which we'll go into right here.
Good timing.
Right, so this green one on the inside here is the ophthalmic one. So it's going to come up and it innervates. Do I have my list somewhere of all the things that it innervates? I know it innervates the upper lid, and it innervates the inside of the eyeball, and it's going to innervate this inside here. It innervates the meninges on the inside of the skull, right? So that's where this ophthalmic one goes. Whereas the one that we saw that we can do the electroacupuncture for is this one called the maxillary branch that comes out. This is the infraorbital foramen. So it's going to come out they all come out of the same hole of the brain, and they come out, but this one comes through here. And on the inside is where all the teeth are, right? So it's innervating the sinuses and the tooth roots, and then it comes out and it innervates the face and all these muscles. And it's not going to cause muscle, it's not motor, it's sensory to the muscles in the skin and everything here. And then the third one is the mandibular branch, right? It's going to come out and innervate the whole lower jaw. So bones, nerves, muscles, whatever. These are all just sensory. So they're just going to come out and then give you sensory information back from those areas. So if you have one that's more photic, where it's more light sensitive, then I'd be thinking there might be something going on with the inner ophthalmic branch, which would be harder to reach, but might be something that you could reach with craniosacral techniques, right, where you can mobilize the skull and look at it that way. Or it might be something that what we're going to talk about with resetting the vagal nerve might be something that would help with it. So you could try those sorts of things. You know, when I hear pink skin, I always worry about liver function. So I'd probably be looking at milk thistle or NAC or something to help detox the liver and give him some support, right? Because if the liver isn't functioning normally, you're not going to be able to get rid of other toxins. So no matter what else you're doing, you're going to be kind of behind the 8 ball. So that would be another thing to think about with that particular case. Mm-hmm.
Do you find that one breed's affected more than another with head shaking?
I don't. I would say that if I had to guess anything, I would say I see more dressage horses with it, but I don't know if I could say it's any specific breed, but I would say I probably see it more in that group than other groups, which might kind of feed into the question of head position, you know, and repetitive strain on the pole, right? You know, so if you have you know, or saddlebreds even, you know, something like, you know, where they're kind of held in more of a flex frame, they're going to create a lot more tension in the pole area, right? So they're going to have more strain on the back side here where the nuchal ligament would be. They're going to have a lot more strain on their TMJ and all the fascia kind of in this area. So I would think those are probably more likely to have problems, but I've seen it in all kinds of different cases. Mm-hmm.
Yeah. So Levy says my gelding head shakes really bad when you try to touch his pole area. The chiropractor and body worker could not really do much for him as he becomes violent about it. She pulled on his ears forward and backward and to the side, and he closed his eyes, nose twitched constantly, relaxed. I wonder why that works so well for him. She suggested to pull his ears. Eventually, I hope we can work on his pole area. He was severely abused by a trainer before I bought him, so I believe this is from an old injury.
So that case is the perfect case for us to talk about going into polyvagal. So let's go ahead and so what was the owner's name? Just so I can remember. What is it?
Levy.
Okay, so if we talk about that particular case, that'll be a great one as we're trying to go through here, because I think that that's probably a really kind of classic sort of trigeminal case for me, is they're super sensitive. Just kind of as an aside, we talked about how the trigeminal nerve is sensory for the head. So the trigeminal nerve is going to innervate the sensation to almost all of the head, except for the base of the ear and the inner ear. And the base of the ear and the inner ear is actually glossopharyngeal and vagus. They're 2 different cranial nerves. So when you have a lot of sensitivity right at the ear, that already tells me I know I have a vagal nerve problem, you know, so just from that. And so I think what a lot of people look at it is, oh, we just have to mobilize the ear. Oh, they must have gotten ear twitched when they were young and they're just not sensitive. The majority of the time, if you fix the vagus nerve problem and you fix the pole problem, the ear sensitivity goes away. So I think that sometimes we work on it backwards when we say you have to get them comfortable before we can adjust them. What we should be really doing is saying, let's just get through this and adjust it so he's not sensitive, and then you won't have to work so hard on it. One of the things that I do that's maybe different from a lot of other osteopaths and definitely different from a lot of chiropractors is I work under light sedation a lot. My first time I work on horses to get through that, anxiety barrier, and because I really want to fix their poles, because I think that that's so critical to resetting the whole body. So I'll always, start with a little sedation if they have a pole issue so that I can get my adjustment and then we can move forward, because I need that vagus nerve free and I need all of these nerves being able to function. So yeah, if they're not able to get there, you're never going to fix it until you do. And I mean, even Dr. Declue, she talks about how important that pole area is, and you have to fix the whole area. You can't just treat the nerve, you have to treat the whole pole to get it free. So this is just kind of, I'm going to review anatomy and then we're going to talk about approaches. So this is the anatomy of the trigeminal nerve, right? This is what we're talking about with head shaking. So there's 3 branches. So the ophthalmic one is way deep in here, and it's all these little ones that you see on the inside of the eyeball. So it's sensory to the upper eyelid, the cornea, that's the clear part of the eye that you can touch with your finger. The lacrimal duct, which is going to be, on the inside here, and the ciliary body, which is responsible for opening and closing the pupil. And then the maxillary part, so the second branch is the one we were talking about that comes out here that we can look at with electroacupuncture. And so it's sensory to the lower eyelid, the sinuses, the upper teeth roots, the palate, the hard palate, like this part of it, and parts of the pharynx. And then the mandibular portion, this is this big one coming down on the jaw. So that one's going to be the masseter muscle, the temporalis muscle. Those are both responsible for closing the jaw. The pterygoid muscles, which are on the inside of the mandible here and allow for rotation of the jaw. So that upper swing of chewing, that's really important. And then the anterior digastricus, so this part. So this area back here, all the muscles that sit kind of on this back side of the mandible are glossopharyngeal and vagus. So they have a different innervation. So trigeminal nerve is doing all the rest of them except that area. And then the other nerve that's really important, because we need to know who does the motor motion, like who's responsible for the motion, what's causing the twitching, is the facial nerve. So trigeminal is only taking in input and sending it to the brainstem. The facial nerve is what is actually creating the motion. So if your horse is doing actual twitching, then you have facial nerve response. If they're feeling it, but you're not seeing twitching at all, then the facial nerve isn't a part of it if they're just throwing their head. But some of them will actually have like little, nerves or little muscles going off on their nose, and they'll kind of wrinkle and all that kind of stuff. So that's the facial nerve. So the facial nerve is going to come out right here. It's this big nerve that's right on the side of the head here. And it's the one that can be damaged, like if a horse gets its head stuck in the fence, or, if we leave him down, like for anesthesia with the halter on, sometimes it'll press right here and it can cause damage. So that's what the facial nerve does. The facial nerve also is responsible for all of the glands in the head. So all the salivary glands, tear ducts, all of that stuff. So just kind of, that's what it does. So if you have problems with that, then you have facial nerve involvement. And then vagus nerve. So this is the one that's going to be really important. The vagus nerve is called the vagus nerve because it wanders all over the body like a vagabond. It's huge. It just goes everywhere. So, it starts up here and it's responsible for innervating all of the organs. So, heart, lungs, stomach, liver, pancreas, GI tract, spleen, all of these things. There's a section at the very back part of the organs, like right in the pelvic viscera and maybe the bladder, that we have often thought had a sacral innervation instead of a vagus nerve innervation, but I guess that's kind of up in the air right now. So we're not discussing that because nobody knows. So in general, though, the majority of the entire viscera is vagus nerve. And then the vagus nerve also does a couple other things. So it has a small section that does motor to the larynx. So if you guys have ever heard of a horse that roars, we talk about roaring as a problem with the epiglottis not opening correctly. That has to do with this little nerve that you see on these guys. So this yellow nerve that you're going to see on the right is the vagus nerve. And so it's coming down, it's coming down, it's going to go into the lungs and then go down further. But do you guys see where there's a little curve here that's going under the aorta, and then it's going to come back up here? So that's the left recurrent laryngeal nerve. And then the right one doesn't have to do quite so much. It comes down and it loops over here on the subclavian and comes up. So these two little nerves are coming up and they're innervating that that motion of the vocal folds and the opening of the airway. So this is, part of that breathing apparatus. So if you have a problem with the vagus nerve and you have a roaring horse, that's what's going on. It's the recurrent laryngeal nerve that's the problem.
So can you think of that the other way, that if you have a horse that roars, you have a vagal nerve problem?
I think so. Yeah. I think you could definitely put that both ways. What we've been doing for centuries is, they have a left recurrent laryngeal nerve, weakness. And so we just tie back the epiglottis or the vocal fold and leave it open all the time. But it would be really interesting if instead we said, this is a real clue that they have a vagal nerve problem and we need to work on the vagus nerve instead. I think that would be a really cool way to look at it, get away from all the surgeries. Yeah.
Which are not always successful, right?
Right. Maybe that's why. So this is it's a really important nerve. This is where it goes. So just kind of review, there's a left and a right nerve. So the left one is kind of unique, and we'll talk about part of that uniqueness when we get to polyvagal theory. But part of what makes it unique is that it mainly stops at the diaphragm. So the left one comes down and it goes to the heart and the lungs. And it has one branch that does go to the stomach and to the liver. But the right one is the one that comes down and does the majority of the viscera. So there's also a huge portion of the left one that is sending signals up back to the brain. And a lot of that is coming from the heart and the lungs. So one of the things that people are starting to talk about is that we have this really interesting nervous system where the heart is actually kind of in control of the brain. And when they're talking about, what they're really talking about is this vagus nerve connection. And there's 80% of what comes up that, that nerve is all of these, heart sensation, different sorts of inputs from that area to feed back to the brain and influence things. And
so are you familiar with heart math?
Yeah, I love heart math.
Okay.
It's so cool. Yeah.
Yeah. Heart math talks. I know, we have to get together one of these days.
Yeah. But that's what they're talking about, is they measure something called heart rate variability. So it's that the rhythm of the heart isn't completely even. So, and it's somewhat related to breath, but not all related to breath. So you should have a slightly irregular heartbeat, not enough that you can hear it, but slightly irregular. And the more of that variability you have, the more your heart is actually functioning in the right space and talking to through your vagus nerve to your brain and back in a way that's keeping you in very relaxed healing mode. And the more that variability goes down, so the steadier your heart rate is, the less parasympathetic, sympathetic, innervation you have, and the more you are in sympathetic, which means you're actually in more of a fight or flight, kind of scared, ready to move position in life. And so that's coming from this left vagus nerve and how it comes back and talks to the brainstem.
And last time I looked into heart rate variation in horses, they're still struggling with that, coming up with sort of a baseline or something.
Yeah. I need to look at that again, because I did buy an ECG unit last year just for fun. And I haven't used it enough, and I was like, I need to dig that out and see if I can figure this out, because I think it'd be really cool to put that on and look at how the heart rate variability changes while doing a vagal nerve reset.
Yeah, that would be cool.
That'd be super cool. Yeah, so something to think about. Future plans. So this is, again, just kind of repeat that right vagus nerve goes all the way down and innervates everything. So And then there are all these little, spinal nuclei that are in the brainstem that are important for the vagus nerve. So the ones that we really want to talk about are this nucleus ambiguus, the dorsal motor nucleus, and the spinal trigeminal nucleus. Those are the ones that we want to really focus on. So, the spinal nucleus they're both on both sides. So they're showing you some of them on one side and some on the other, but you can imagine that spinal trigeminal nucleus would be sitting right under these on this side as well. So the reason that that's important is that the nucleus ambiguus is going to be the one that's going to help us influence the vagus nerve portion that we want to have, the positive portion of the vagus nerve. Whereas this dorsal motor nucleus is kind of our primitive vagal nucleus. So it's going to be more related to the GI tract, like we were talking about, and that right vagal nerve. And the nucleus ambiguus is going to be more of the left vagal nerve. But it also has some connections into the pole area. And then they're both going to send, this vagus nerve is also going to send afferents into the spinal nucleus, which is going to tell it like what's going on with the body. But then also we're getting all of this, signaling from the trigeminal nerve of the head into the same nucleus. And so that means that if one area is hypersensitized, it's going to feed back and affect the other areas of the body and could create hypersensitization, right? Because it's all one big cell body, one nucleus in the brainstem. They're close enough that you're going to have effects. So this is one way that we can have a feedback loop where sensitization somewhere else in the body, like let's say in the gut or in the heart or in the lungs or something that the vagus nerve innervates, could feed back and create an increased excitation of the trigeminal nerve, because this is the trigeminal nerve and it has nerve bodies that are then creating they're doing the sensory for the head. Does that make sense? Am I losing you guys?
Okay, so let me see if I can summarize this. So the brainstem nuclei, this is where everybody's coming together.
Right. This is where it all comes together. So
Okay.
You have sensory input coming in from the head, and you have sensory input from the vagus nerve that actually comes into the same nucleus that's telling us, like, what is my heart rate doing? What is my blood pressure? What is my gut doing, right? So anytime we have a problem in the body that increases sympathetic feedback, it can change how that nerve is then firing. And so I think what can happen here is that those inputs from the viscera can create more of like a heightened, awareness of the nerves. And then because these nuclei are maybe more hypersensitive, the feedback in from the nerves of the head could be considered hypersensitive, right? Because they're coming into an area that's already hypersensitive.
So basically everybody's kind of sitting in this little place and one gets excited and it kind of excites everybody else. And so you get head excitement along with gut excitement because vagus says, hey, your gut is busy. And then you go, oh, my head is busy too.
Right. You got it. Yeah, that's yeah. Thank you. Thank you.
No problem.
No, that's fine. So, knowing that about how these are connected, I want you guys to at least kind of know the idea of how it's connected. Then we get to this idea of polyvagal theory. So this is something that has been around for 10, 20 years at least, probably much longer, but it's definitely kind of becoming more mainstream and people are talking about it, especially in horse training. And I think it makes what I do make complete sense. So it's kind of one of these things where I'm like, this is great. This is perfect, especially for head shaking. So the theory is that we have three sort of evolving portions of the vagus nerve that have occurred over, millions of years. So the primitive vagus is what's been around since fish. And that's the one that, we see on the dorsal side. So that's the right vagus nerve that's going into the gut and doing all of that. And this is our basic parasympathetic. It can, if it's not working functionally well, you could have ulcers, you could have colitis, you could have things like this. But what it tends to do is, in the face of stress, it causes almost like a freeze response. So an immobility, a lack of almost like a shutdown, sort of completely depressed, vacant, not really participating sort of situation. So, back in the day when a fish got caught by something else, it kind of needed to go into that mode. And, when you're talking about cold-blooded animals, they could actually kind of stay in that mode long enough that maybe whatever caught them would let them go, right? So it was somewhat protective. It's not protective for mammals because we have to breathe and our heart has to beat, but that's kind of where it comes from. So and then we have the second stage of the vagus nerve that happens and is there even in the reptilian animals, which is the sympathetic system. So it's a completely different system than the parasympathetic, which is vagus. So the sympathetic system has its own wiring, and it's really responsible for our fight or flight response. So that's what, helps coordinate your motor. It sends blood into your heart and your lungs. It takes it away from the gut. It makes everything really contractile. It increases your heartbeat, it kind of gets you going. But it can also cause tenseness and contraction, right? So something that's in sympathetic state is going to have really tight contracted muscles, hypersensitive nerves, hyperactive. They might be more reactive than normal. They're kind of on edge all the time. So I think that kind of would be something you could say about trigeminal horses, that have head shaking, is that their head is in a sympathetic state. So just kind of thinking about that as what's going on. And then this third stage is what had to kind of evolve for mammalians to really work. And it has a lot to do with needing social engagement for just basics when babies are born, right? So when a mammalian baby is born, it has to interact with its mom, it has to nurse, there's a lot of vocalization, there's lots of touch, and in the process of all of that with suckling, there's a lot of facial expression, there's facial muscles that have to move for suckling, so all of this sort of gets involved with the feeling of security and safety. So when we talk about trigeminal hyperesthesia, or like we are with head shaking, I think we're really dealing with something that's right about where this new parasympathetic, vagal complex is, because we're talking about the muscles of facial expression, and we're talking about sensitivity there and feedback. And I think it just really fits. So that's where I think we need to start, is by thinking of this as a part of a polyvagal complex problem versus looking at it as a diagnosis of pathology of the nerve. So if you look at it that way, right? So like we were talking about, that primitive vagus response would be a freeze response. So I think about that as those horses that, everybody says are lazy and you can kick them forever and they'll never move. And when they do finally move, they kind of lurch forward and they do something that you didn't expect. Those horses are in their primitive vagus nerve. They're not using their sympathetic nervous system anymore. It's shut down, and they're not using their ventral vagal nervous system anymore. Like, they're not interactive. People think that they're quiet, but they're into this mode. They've already passed everything else. And so that's what that looks like. And then the sympathetic system is your fight or flight, like we talked about. They're going to be that tense individual. So the ventral vagus is where we want them to be all the time. So that's like when Wendy has them on the pads and they're licking and they're chewing and everybody's happy, right? We want them to be stretching, and we want their tongue out, and we want this facial expression. So that's what we're looking for. So when you want to get to that, you have to remember that if you don't have the ventral vagal complex working, they're in sympathetic. So the ventral vagal kind of controls sympathetic. But anytime they get stressed, or they don't feel safe, or they have a lot of pain, then you're going to get them into that sympathetic system instead of staying in the ventral vagal complex that we want them to be in that portion of it. So I think that that's where a lot of these trigeminal horses are, is that they're not feeling, they don't have that safe, secure, unpainful feeling anymore. And that part of their system has stopped working. And they're in this sympathetic system. And sympathetic system triggers can be global, right? So as osteopaths, we talk a lot about the autonomic nervous system, which is why this is like right up my alley. So anytime you have immobility, you'll have local sympathetic increased tone. So if there's a part of the spine that doesn't move, we talk about it having increased sympathetic tone. If they have inflammation in the body, they have increased sympathetic tone. If they have stress, they have increased sympathetic tone. So I think that a lot of our horses kind of live with a lot of excuse me, let me start over. I think they live with a lot of immobile areas of their body. And I think that that is part of why they live in this sympathetic zone instead of living in the more, positive ventral vagal zone that we want them in. And so if that's the case, if you have a horse that, let's say, has a really rigid spine, doesn't use their back well, they're going to have increased sympathetic stimulation to that area. And then that's going to mean that they have more active norepinephrine in their whole body, which means that their whole body is in this sympathetic state. So one of the ways that we treat that is that we use habituation and desensitization, right? So a lot of training methods, or like we were talking about with the nose nets, anything that is creating a way to numb the sympathetic nervous system. You are getting rid of that sympathetic response, you're getting rid of the pain response and the hyperesthesia. But what you're really doing when you do that is you're going, instead of going to ventral vagal, you're going into that primitive vagal. So you're taking them into freeze. So we're not actually fixing the problem, we're just numbing it. So when we do something like injecting with the steroid, or when we do something like Shockwave, or we do something like electroacupuncture, we're really affecting it to habituate and desensitize the sympathetic nervous system. So then we're taking that one out of play. So we already have the ventral vagal not working. And then now we've closed off and stopped the sympathetic system from working. So now all we have left is this primitive vagal. So we're in freeze. And we're calling that a success because we don't see the response. But what we've actually done is shut down the whole system even further. And then you end up with ulcers, and then you end up with all kinds of other problems because you have a dysfunctional system that can't heal. So you really have to be in this ventral vagal zone to have true healing of the body. There's another great website from Equisoma that talks about all of this from a psychology standpoint. So
yeah, I've had her as a guest. It's a great webinar. If nobody's watched, go back and watch.
It's amazing. So, just thinking about this, but I'm kind of taking it to that sort of body state versus the psyche state. So what we want to do when we activate the ventral vagal branch is calm the viscera, calm the facial muscles. We can actually activate the nucleus ambiguous, calm that, get it where it needs to be. And then we can take, as soon as you get that ventral vagal system working, you can then take control away from the sympathetic system and away from the primitive vagus, right? And go back to a functioning system. So I really think that that's where we need to go. And there's this amazing book that's been out for a while. So, those of us that do visceral osteopathy, you have to get it from humans because we don't have a lot of equine people doing all of this work, but this is what they do.
What's the book called?
It's from the Boron Institute, and it's called The New Approach to the Vagus Nerve and the Autonomic Nervous System. And basically all they talk about is all of the different things you have to do to reset this. And you have to get every single spot that the vagus nerve could be restricted. So you have to mobilize the trigeminal nerves at their output from the head. You have to mobilize the pole. You have to mobilize the TMJ. You have to mobilize the fascia around that. You have to mobilize the fascia around the neck. You have to mobilize the thoracic inlet. You have to mobilize the thymus. You have to mobilize the diaphragm. You have to get the stomach and the esophagus. And if you do,
okay, this is not a layperson. This is
right. Like this is that's what I have to do as an osteopath. If I hit all of those things, then I can get the vagus nerve to reset. And so I can do it that way. So, for me, when I treat these head shakers, I just go at it from that point of view, that if I can fix the vagus nerve problem, I can reset it all. And then they're back to a more normal state. And so then as long as we don't get back into sympathetic, they're fine. which is what the owner needs to know, is that if you can find a way to treat them so that you can really affect that vagus nerve, I think you can kind of reset, and then you're back to more normal until you, whatever that trigger was, until you hit that trigger again. And what that trigger is usually doing is shutting down the ventral vagal complex and the ventral vagal nerve. So if you can figure out what's upsetting the viscera, and you can figure out what's stressing the horse, then you can prevent that sympathetic relapse.
Somebody woke up from her nap. So
yeah, so you know, that's kind of how I do it. Is I start with my biomechanical manipulation, my osteopathy, really work to get into the cranial sacral, and then I use a lot of nutrition and GI work to make sure that I'm keeping the gut healthy and I'm keeping things happy there, so that that's not a stressor. And then I try to eliminate any training or situations that are causing the stress, and make sure that I've got my dentistry so that I have a balanced mouth, so that doesn't upset the TMJ and the fascia around there. And then usually that they're fine. So it's a simple end to a very complicated problem, for lack of a better way of explaining it.
yeah, but you know, more and more we're realizing the importance of the nervous system, and in particular the vagus nerve, and how we've so not taken into account the sense of safety that horses need to learn. And
Right.
And so we've in many ways created a lot of problems because we blow past that into other techniques to try and accomplish a goal, but we push them into different states of disease, you know, and shut down. I mean, there's a lot of horses that are in states of shutdown, or Robin Hood coined the term slush. You know, they're still functioning, but they're really slushy, in order to be able to control them. And so, you know, it takes a lot more effort to be able to educate a horse to be able to become resilient and keep the nervous system more healthy, than it does to just push them into a state where we can dominate them, I guess is for lack of a better word.
Yeah, I think I think that learning to be patient and learning to not have an agenda and learning to make time with your horse, time to connect with your horse, right, versus time to go do 30 minutes of trot and 15 minutes of canter, and you know, whatever it is that, like, so many of us are, you know, we have a goal, and I think when you get back to it, your goal just being connection, that creates a lot of security for the horses. And I think that, you know, if that's truly what the vagal complex, the ventral vagal nerve is about, is engagement and connection, then you have to have that first before you can do anything else, or you're going to create a sympathetic nervous system, you know, that's in charge. And as soon as you do that, you create a body that's got a lot of inflammation, and where the GI tract is not functioning and the body can't move and the muscles aren't getting enough blood, and, you know, the nerves are firing more than they should be, you know. And so I think when we start looking at it from a biological standpoint, if you want your horse to last or be happy or healthy, this is where you have to start, is by creating that, you know, whatever you need to do to get the environment right, so you live in the world of the ventral vagal nerve instead of the others.
And you know, so many, you know, I just worked with a thoroughbred today who's come off the track and has anxiety issues, for lack of a better word, which are so often written off as he's doing this on purpose, as opposed to he's habituated into this. When he feels this stress, he's going to slam you against the wall, right? And to help get people to look at it from the perspective of, you've just exhausted his nervous system in terms of coping and driven him to the most habitual pattern of coping in that moment. And how can we avoid driving him there so that we can actually teach him something so that he can use his body and be functional? And, you know, it's, it's complicated. It's simple and it's complicated, right? I mean, that's the thing is, but we have to start with understanding they're not, people want to go, oh, well, he's just being a pig, or he's just doing this to me, or he's just fill in the blank, instead of this is how his nervous system is reacting to this stimulus. And so, it's not directed I'm just throwing pennies at the cat to keep her from scratching at the carpet. She wants out. Then she thinks the penny is something curious and she goes and looks at it. She doesn't run away. But we have to start with a change of mindset, I think. And the change of mindset has to be, this isn't the horse doing this to me to make my life miserable. This is the horse's reaction to stress.
Right. Yeah. Well, and I think that's exactly it, is when we start recognizing that, that horse that is really tense is already super stressed and is at a point where they could get injured, and can cause problems. And if they're not giving you the super stress look, but they're not paying attention and they're completely out of it, then you're beyond, you're even further down the track of creating damage, right? So like, you want them to be super interactive, and they should be, curious, and they should be looking at you, and they should be, in that parasympathetic state where you can, see the yawning and see the licking and the chewing and all of those things, because that's where true health is. So just from a standpoint of, without even going to the emotional connection, which is, I think, what all of us, I hope, want with our horses, just from a health standpoint, that's where they need to be if you want them to be healthy and last and perform well for a long time. Yeah. So, but I do think that head shaking might be a really great area to kind of focus on, as far as because it's right there. It's right where the vagus nerve and the trigeminal nerve all connect. That this would be kind of the perfect example of a problem that is truly a polyvagal problem. And if you can treat it that way, I think you're going to get a lot further than that's why the conventional treatments don't work, right? Because that's not what the problem is.
They're not addressing the stress that's causing it, whether it's a physical issue like the horse we talked about earlier, or a photic issue or whatever. There's a stress in the system, and if we could calm the system, then we can reduce or eliminate the issue.
That's exactly right. Like, so that one that I said was the perfect example. I think that that's where they need to start, is with the, start with some polyvagal, look that stuff up and see if you can just start with some of the little behavioral techniques they have for kind of engaging that system. And I think if you started there, you probably get a lot further than, all the other stuff that you could do. And then once you get there, then maybe it would be easier for someone to do the body work to really mobilize the vagus nerve at all of those points. And then once you do that, you're going to be golden.
So Dorothy says, it makes complete sense with my horse. I think he lived his life in fear, and his body wouldn't be able to run away if he needed it to.
Right. Yeah. So yeah, I think that, I would definitely look up, start looking up some of the people that are doing the training with it, and start with that, because you can do that on your own. I think that, like Wendy and I were saying, we need to figure out how the Surefoot pads work into this, because they're doing something with it. We're not quite sure. I can't define for you today exactly how Surefoot pads fit into connecting to the vagal nerve. I think it has something to do with peripheral nerve stimulation and how that connects in, but I'm not smart enough to know that right now.
I don't think it's that you're not smart enough. I just think there's more that we need to know. And the one thing that it fascinates me when I do Surefoot with horses is that they recognize I'm safe to be with. Right? When I do it in a way that's honoring them and listening to them and giving them choice, which is so critical, then they're like, oh, you're an okay person to be with. And and I think that there's so much in that choice that we have to give horses choice. And one of the choices is no, and it's okay.
Right.
It may not be no forever. It might just be no for a moment, or it might be no for a week or a month or a year, but then it becomes yes. And I've seen that happen in so many different ways. But by allowing them that opportunity, and obviously, if it's unsafe, we have to take that into consideration. And I get that part, right? But otherwise, it's like, if we can give them that moment of choice and say, okay, you can't do it at this moment, but let me wait for a second, and maybe you can do it at this next moment. And then what I find so often with Surefoot is that when the tension is reduced, when I put them on pads and they relax a little bit, they can already do what I've been asking. The anxiety was what prevented them from doing it, not the understanding. They understand, but the anxiety is holding them back.
Right. Well, they're not in their head. They're kind of, they're either like in that tense, I have to fight or flight mode, or they're not listening anymore. And, once the anxiety hits. Yep. So you have to get through that to be able to get to anything else again. Yeah. So, if any of you guys have questions, or you have a tough head shaker case and you would like to talk about your specific case, I'm happy to kind of work through what you could or could try, or, maybe some exercises to try, or if you're close enough and you want me to look at your horse, whatever it is, please feel free to reach out. You can just, email us at True North Equine. I think it's just office@truenorthequinevet.com, or you can go to our Facebook page and message us and we can reach out to you. We're trying to kind of find a way to create some way to have a network that has all kinds of great people that would be all the different avenues you need to really create that, holistic horse health for you. So I'm working on that, but if you reach out, maybe I can find, the right person for what you need to get started on this.
Well, Ann Marie, I want to thank you so much. Yet another really fascinating webinar. And I'm looking forward to us getting together one of these days soon, I hope.
Yeah.
Yeah. All right. All right. Well, thanks everybody for tuning in. And just remember, you can find this and all the other webinars on the Surefoot Equine YouTube channel. Ann Marie has a playlist, so you can find all of her webinars on Ann Marie Hancock playlist. And thank you for tuning in. We'll send out an email with the next time we're going to be here, or you can find us on Facebook. Thanks a lot and have a great day. And thanks, Ann Marie.
Take care.
Bye.
Bye.